complications that happen in fixed prosthodontics. So they cover over 50 years of length of time, looking at various papers, looking into specifically the success, failures, and also complications of single crowns, bridges, or ceramic crowns, post and core, and resin bonded bridges, and fixed bridges as well. So all in all, the area that they look into can be divided as such. So single restorations or link restorations. So as you can see now, single restorations tend to have lower failure rate as compared to link fixed prosthodontics, for example, conventional bridge work, fixed bridge, for example, or cantilever bridge, and also resin bonded bridge. They tend to have higher failure rates. So what are the failure rates that we can see in fixed prosthodontics? So there are the common areas that they look into. So I have gathered and summarized in these slides at what are the common complications that may occur. So for all these fixed restorations, loss of retention is one of the key failure or complications. I also need to alert that this paper was done almost 18, 19 years ago. At that time, most of the time we use non-adhesive technique in comparison to nowadays. We use more adhesive technique. We have resin luting cement, you have universal cement, which has higher bond strength in comparison to previously when we use zinc phosphate, zinc polycarboxylate, which has lower retention capability. So that's why loss of retention is one of the core failure, followed by needing RCT, i.e. there is secondary caries that happen underneath the crowns and bridges, which we still see quite a lot nowadays if encountered in the clinical situation. So loss of retentions, why should we encounter loss of retention? We have prosthesis that has been put on short clinical crowns. So how do we overcome the situation of short clinical crowns? Of course, first of all, we need to have a very sound treatment plan. And how do we increase the success outcome? In order to overcome this short clinical crown issue, we can do crown lengthening, we can do orthodontic extrusions, and for poor cementation technique as well, it lead to higher failure rate during clinical service as well. So what could lead to poor cementation technique? For example, improper mixing, especially you have toothpaste system where you have to mix the toothpaste. Nowadays, due to advanced technology and research, a lot of systems come with auto mix now. So auto mix reduce the human error in proper mixing, in over mixing, or contamination during mixing as well. So a lot of companies have come up with the auto mix system. And wrong choice of cementation materials. You know, when you need maximum retention strength for the prosthesis, for example, you need to maximize on the adhesion outcome. So if you are using a cement that may be suitable for your full coverage crown, they may not be suitable for prosthesis that requires more retention. For example, veneers, resin bonded bridges. So you can use nowadays the so-called self-adhesive or universal cement. But this group of cements are not suitable or not strong enough to cement resin bonded bridges. So for resin bonded bridges, you still need to rely on the proper resin luting cement and using a proper cementation protocol. You need to have a treatment for your tooth, for example, etch and then bond with dentin bonding agent. It can be either selective etching and then you use non-rinse dentin bonding agent. So you need to really understand the cements that you use to maximize the adhesive outcome. Or the other factor that would lead to cementation failure include over-tapered preparations. A lot of times, due to access issue, due to lack of experience and manual dexterity, we may end up with over-tapered preparation. That would also compromise retention and resistance form of the prosthesis. And the other factor that may lead to cementation failure include insufficient rigidity in the castings. For example, if we are providing a resin bonded bridge, the retainer, or more commonly we call the ring of the resin bonded bridge, is not thick enough. Although we use base metal, we still need to have sufficient thickness for the base metal so that it won't flex. If it's too thin, the base metal will still flex under occlusal forces. So once it flexes, it will stress on the cement loop. Once you stress on the cement loop, it will cause debonding. So these are the areas that we need to pay attention to avoid cementation failure. So I would like to just share a case with you very briefly. Although this is a full reconstruction case, but the main aim here is to share with you how we can increase crown height, overcoming short clinical crown to maximize the outcome of cementation success. So this is a patient, a relatively young patient, 31-year-old, who has unfortunately diagnosed with hypertension since she was about 20. So she has been on antihypertensive amlodipine in particular, which is a calcium channel blocker for the past 10 years or so. So this has led to gingival hyperplasia, which is one of the known side effects of the antihypertensive drug that she is taking. So this is what happened to her dentition. I know although she really have a lot of wear on her dentition, but on top of that, if you can see, she also have gingival hyperplasia. There's a lot of false pockets around her anterior teeth especially. I would just like to share that for crown lengthening, usually if you do one tooth, it's quite difficult to get a good outcome because you still limit by the interproximal alveolar bone height, because you also don't want to compromise the adjacent teeth support as well. When you are doing multiple teeth, then the success outcome would be more prominent. So for these patients, the main issue with her is that the crowns are really, really short. And some of them are actually deciduous teeth as well. For example, this canine is actually a C. Are we able to restore it? Some of you may say, oh, it's almost like a retained root. But hang on, you can see after crown lengthening, we are able to get better crown height. And with the adhesive technique, we are able to restore it. So first issue is very short crown height. The second issue is lack of restorative space. There's literally no space for me to put in my crowns and bridges. We are trying to do minimally invasive dentistry here. So we are lacking of the restorative space. And the third issue, as I mentioned before, she has gingival hyperplasia as well. So how do we do the treatment plan for this case and step by step execute it? So the treatment plan is she needs a full mouth rehabilitation. And to be honest, I actually explained to her, I really don't know how long will it last. She's still relatively young. So we try to go minimally invasive, at least that will last her for 10, 20 years. And later on, eventually, if all these teeth has seen the light of it, then we may have to put in implants with a full fixed prosthesis. But in the meantime, we try to do as minimally invasive as possible. So we plan as such that we increase the vertical dimension. If we increase the vertical dimension for about 3 mm in the anterior, that would be sufficient for me to have material in to restore the anterior. And as we all know, because of the curve of spay, if you increase 3 mm anteriorly, posteriorly, you will not be able to gain that much. So posterior, normally, you will gain around 1.5 or so. So what happened is some of the lower teeth, as you remember, they are actually deciduous teeth and they are really very short as well. So if we can just go back a step, you can see here, some of them are actually deciduous teeth. They are D's and E's. Because they are firm at this point in time and there are no successors. She doesn't have any premolar at all. So we try to maintain the space and try to maintain the bone. Keep it as long as possible until at the time we need to actually take out her teeth and then plan for a proper implant supported fixed prosthesis. So what we plan is we have composite, very minimally invasive for the lower anteriors and also for the D's and E's as well. Eventually, I actually build up all with composite and only the molars I put in crowns. So this is the treatment plan. So, and step by step, we plan as such, we stabilize the anterior to provide protrusive guidance and lateral excursion, giving a canine guidance. Then only we do the posterior, where we plan for full coverage crowns for all the uppers, 1.4, 1.5, 1.6 to 4.5 to 6. As I mentioned, lowers, they are mainly D's and E's, so we only provide crowns for the 2 molars. And for the retained deciduous teeth, we put direct composite. So this is the results that we get. I'm very fortunate to have a periodontist in the school that is very skillful. So this is a result after a month or so. There's still marginal gingivitis as such, because I think immediately after surgery, the patient is still a little bit reluctant to brush too vigorously in that area. But take a look at this canine here. You know, this is actually a deciduous canine. But like I mentioned, I would like to retain all these teeth as much as possible because they are firm. Surprisingly, because there's no successor, so there's no resorption of the root. So this canine is still relatively firm. So eventually we do full coverage crowns. When all the gingiva has settled down, that was about, I think I waited for about 2.5 to 3 months or so, let the gingiva settle and firm up, then only we proceed with the crown. So you can see now how much we have gained from the start. This is the starting point. And after crown lengthening, we have gained reasonable crown height. I would say we gain around 3 millimeters. So this is a crown prep. You can see how tall I can achieve in comparison to when she first came and see me. So this is after crown prep. Basically, because I am going to increase the occlusal vertical dimension for about 3 millimeter, I just put just prep a gingival margin on it. The rest, I just round it off wherever there is sharp edges. That's all. And then we prep it for impression. As such, I normally, it may not look that tidy, but I normally during secondary impression for the retraction cord, I leave out a little bit of the cord so that I can gently take it out one by one without traumatizing the gingiva. If you were to embed all the retraction cord inside, then you try to figure out where is the start and end, and then you use a sharp probe to probe around. That would traumatize the gingiva potentially and then cause gingival bleeding. So that's why I just leave out. I normally let my nurses cut a little bit longer. Just pick up the end bit and then gently take out one by one. This is very easy, especially when you are doing multiple crowns and bridges. So this is the results that we gain. You know, all this canine to canine, they are all full coverage crown. They are lithium disilicate because the patients want something relatively aesthetics. So I stabilize the anterior segment, get my protrusion and my canine guidance right before I proceed to the posterior. So resin bonded bridge. Let's go back to what literature has shown us. How long will it last? You know, resin bonded bridges have been there evolving from previously Rochette bridges, and then you have those salt that has been put in to create retentive form until now. I think it has been there for about 50 years now. But I understand that in private practice, a lot of practitioners still have reservation to it. So I'm a bit more lucky in a way because we are in the institution. Patients accept what generally are more accepted to what we propose to them, as long as we explain to them and communicate it to them properly. Because if patients can't afford to have implants and then both the adjacent teeth are sound, patient doesn't want to wear removable prosthesis, resin bonded bridges are very, very good alternative, very, very minimally invasive. So let's look at what literature tells us. So this is a very comprehensive systematic review that was published in 2017. Look at extensively papers. These are all clinical papers that has been published over a period of time, and they evaluate those prostheses that has been in the mouth for at least 5 years or so. So out of this that fulfill their inclusion criteria, they pick up 29 published papers, and cumulatively from this 29 is 2003 resin bonded bridges. And the survival that they found at 5 years is 91.4. I would say for such a minimally invasive and simple prosthesis and achieve a high success rate of 91 for 5 years is a very fair success outcome. And at 10 years, you still maintain almost 83% of survival rate. Again, for such a minimally invasive prosthesis, it is really a very good outcome. And the next thing, what we need to evaluate is in the event that complication happens, it's merely debonding, which is not of severe consequences as compared to other prostheses when you have fracture of the tooth, when you have, for example, recurrent caries until RCT needs to be done or non-salvageable. And also the other complications that normally occur is minor chipping, which happen to a lot of other fixed prostheses as well. And they also found that RBB nowadays with zirconia framework showed a good success outcome as well, and with one single retainer. And this has been communicated with us through various literature that we know cantilever type of RBB tend to have better success rate, because if you have two wing, the two teeth at the side have differential movement because your mouth is curved. You don't have a mouth that is straight when everyone moves together in the same direction. So when your mouth is in a curvature, so the direction of movement vary from one to another. So if you have differential movement like this, you tend to stress on the cement lute and cause failure. And Professor Michael Botello from University of Hong Kong, again, in a university setting, they tend to do quite a fair bit of RBB as well. So over a period, they look at 269 prostheses that were placed over 214 patients, and mean life of service is 51 months, which is about 4 years plus. Again, quite long clinical trials. Of all these 269 prostheses that they cemented, 12 debonded over this period of time, giving a clinical retention rate of 95, which is very good, you know, really for minimally invasive restorations, that provides a very good outcome. So how do we maximize the outcome success of resin bonded bridges? First, the framework needs to be rigid. As mentioned previously, for RBB, we mainly use base metal. And base metal, although it's tougher than precious metal, still they need to have adequate thickness. And generally, we say around 0.7. So we need to evaluate the occlusion. If we do not have that amount of space, you may have to prep the tooth. But when you have to prep the tooth, try to keep it as much as possible within enamel, because we all know that adhesive bonding to enamel is way more superior than to dentin. So if you have more enamel, that would give you better success outcome. And for posterior, I do resin bonded bridges as well in selective cases. So patient selection is also very critical to be able to evaluate the prognosis as well. So for posterior, I normally have a few principles that I follow. First, I usually prep a recit, just like a removable prosthesis recit preparation, and then I maximize the wraparound. So if you have molar, try to extend the whole palatal surface or the lingual surface of the molar. And I also try to do a cuspal coverage as much as possible if it doesn't interfere with the occlusion. So occlusal evaluation is very important. As we all know, occlusion is the keyword for success outcome in fixed prosthodontics. So look at the occlusion whenever it is possible. Do a palatal cusp coverage because it's upper teeth. If you put a bit of metal there, it won't be visible from outside and it won't compromise the aesthetic outcome of the prosthesis. So if you have a short clinical crown and you have a little bit of leeway to do electrosurgery, then you can electrocauterize the gingiva a little bit to increase the crown height so that you have a maximum coverage for your wing retainer. And as mentioned, keep the preparation within enamel as well. So I just would like to share a very simple case that, you know, I learned from my own mistake as well. So this is Jay. Jay is a 42-year-old male. So he came in, he wanted to replace his missing tooth tree. It's a canine. So first rule is look at the occlusion. There should not be any excursive forces on the pontic. Second principle, as mentioned, maximum coverage. So I just want to show you this is the first prosthesis that we issued to him. You can see there's no palatal coverage. The wing is a small, tiny wing that only maybe cover 30% of the palatal surface. So, well, this is a formula to failure, right? As I mentioned before. So true enough, this prosthesis de-cemented after about 2 years plus of cementation. So he came back, we explained to him, possibly we may have to redo a new one. But for the time being, we try to cement it back for him. As we all know, once a resin bonded bridges fall out, if you re-cement, chances are there and risks are there for the prosthesis to de-cement. And true enough, after about 9 months, 10 months, he come back. So we explained to him, shall we redesign the prosthesis and this time to have a palatal coverage. So this resin bonded bridge has been there for until now about 4 years plus already, and it's still there. So what is the take home message here? First, no excursive forces on the pontic. That means when you do lateral extension, when you protrude, there shouldn't be any force on the pontic itself. Second, maximum coverage. Normally do a rest-sit to increase the resistance form and also palatal cast coverage as well. Improve the retentive form of the prosthesis. So mechanical failure in fixed prosthesis, which is quite commonly happen. You know, failure of the bonded ceramic, the layering ceramic, because it could be due to inappropriate tooth preparation, contamination during the laboratory preparation. Normally, when we do ceramic work, the lab has to be really, really clean to avoid contamination. Once you have contamination within the ceramic when you fire, that would compromise the integrity of the ceramic and lead to crack propagation and failure. And solder joint failure as well. Sometimes the technician actually section it and then re-solder the prosthesis to improve the passive fit. So if the soldering was not done properly, again, it may fracture. And pontic design as well. Whenever we communicate to the lab, we need to be able to design the pontic. So don't leave it to the technicians to design the pontic. You as a clinician need to be able to discuss with the technician and see what pontic design do you want. It needs to be functional, aesthetically pleasing, and also enable the patients to clean it properly. So do not have a concave surface on the part that touch the gingival area. So if you have a concave surface, food tend to trap there and it's very difficult for the patient to keep it nice and clean. So this needs to be bear in mind. So if you receive a prosthesis that have a concave surface, you as a clinician, you can modify chair side in order to make it less concave, enable the patients to clean it properly. So this is very important to observe. And you also need to teach the patients for the maintenance as well. You need to teach them how to use flossing technique that enable you to clean underneath the pontic area. Inflection and fracture of metal, as we have seen earlier, that when you do base metal or other full metal prosthesis, even for implant as well, you need to have adequate metal strength in order to avoid fracture. You know, nowadays we do see, because we have a lot of screw retained prosthesis for implant supported bridges or crowns, we occasionally see even fracture of the fixture screws as well. So if you have a piece of screw that is really thin and also with the heavy occlusion as well, these two things come together will lead to high risk of the screw fracture. So again, we need to be able to communicate with the technicians and give this piece of information to them. And when the prosthesis come back during issue time as well, you need to be able to have adequate talk, not over talk it, and you stress the prosthesis. And also when you do the occlusion adjustment, as we all know, our natural teeth will have the ability to depress in the periodontal socket. But for implant, they do not get depressed. They only have the elasticity, a little bit of give for depression only. So when you do occlusal adjustment for your implant supported prosthesis, you have to ask the patient to bite maximum. So other teeth are all depressed maximally into their periodontal socket as well, so that you don't overload your implant as such. And all ceramic restorations, we need inherently, although even it's zirconia, inherently ceramic are quite brittle material. So if you do not have enough thickness, in general for zirconia, we said about 1 millimeter, 1.2 millimeter, not less than that, especially in the posterior area when you have high occlusal loading. So fracture of veneering ceramic can be very frustrating for both the clinicians and also for the patients. So first up is the manufacturing. So the technicians need to be take extra care to ensure that the layering of the veneering material is properly done. In the event that failure has occurred, how do we overcome it? Do we take out the whole prosthesis and redo, or we can actually repair it? Generally, we can repair the ceramic if the fracture is not involving a large area. If it involves metal, like in this case, then it may be a little bit compromised to repair it, because the bonding of the composite to metal is not as good as the composite to ceramic. And also masking of the metal as well. You need to have a composite opaquer to mask the gray appearance of the metal. So first up, rubber dam isolation. We generally cleanse it with pumice and water, and then we roughen the ceramic as well. You can use a high-speed coarse diamond, very gently, just bevel it, roughen it, and then we apply a buffered hydrofluoric acid, generally around 8–9% or so. If there is metal exposed, to increase the success outcome, we can air abrade them. You have a lot of different systems that would enable you to do air abrasion tear site. For example, Kojak or AquaCare. The particle size has to be small because you don't want to create micro cracks in your ceramic. So in general, we say around 50 micron aluminum oxide. And the blasting pressure as well, keep it low, no more than 2.5 bar. And then if you have metal bonding agent in your clinic, better seal. You can use metal bonding agent. Otherwise, we can apply silane, because silane is a bipolar molecule where one side of it will latch onto the silica from the ceramic material, and the other side, they actually can bond to the composite that you are bonding on. All right. So etch with hydrofluoric acid, 9%, apply silane coupling agent, and then dentin bonding agent, so that you maximize the bonding between the ceramic to the composite. So the silane will act as two-pronged bifunctional molecule to link the silica from the ceramic material to the composite. And then we can repair it with composite material, which is relatively minimally invasive rather than us having to change the whole prosthesis. Okay, occlusal wear, opposing ceramic for years and years. Is it a myth or is it a fact? We all know, we have seen clinically a lot of time dentition that is opposing ceramic get worn down. So what does the literature tell us? What is the fact about opposing ceramic material on wear to the human enamel? So we look at an in vitro study, and slowly, I will bring you through in vivo and also in vitro study and what are the findings. So this is an in vitro study looking into 4 different ceramic systems. It's a variety of ceramic system. You have lithium disilicate, which is the Emax. They look at both Emax press, which is a lost wax technique, and Emax CAD as well, which is using a CAD-CAM technique. So Emax press meaning to say you wax up the whole crown and you manufacture using a lost wax technique, just like what we do for metal casting. And then the CAD-CAM, of course, is milk. And then they also looking at Noritake porcelain and also lava. Lava plus is the zirconia restorations. So they use a wear simulator because this is an in vitro study. So they use a wear simulator and they use digital scanner to look at the outcome of it. And they conclude that there is no difference that were found in the wear for enamel that opposing any of these 4 ceramic that they look at. All right. So this is what they found in vitro study. So next up, we look at a more comprehensive systematic review and meta-analysis of in vitro and clinical studies as well. All right. Bear in mind earlier what the other paper said about equal wear for both zirconia and lithium disilicate. And what does this paper tell you? So this paper tells you that for randomized clinical trial, they attest that the monolithic zirconia produces enamel wear. Because in vivo, in human being, when we eat and chew and perhaps sometimes bruxing at night or clenching at night, it's quite different from a dental simulator that we use in the lab. So that is a fact. So this paper has mentioned that randomized clinical control trial attests that there is wear for monolithic zirconia as compared to in vitro. In this particular systematic review, they look at all the in vitro paper and they agree also that in vitro, the zirconia doesn't wear out the enamel. So clinically, we need to be aware of this. Okay, so we use zirconia restorations quite a lot now. So when we try to minimize it, so which are the all ceramic systems that we use? You know, we need to balance between aesthetics, function, strength, ability to withstand occlusal loading. So for posterior, generally we use monolithic zirconia. So monolithic zirconia tend to cause less enamel wear according to this systematic review when compared to the conventional feldspathic as well as heat press lithium disilicate. So that is quite a good news in a way. Zirconia is strong and they cause less enamel wear. And another study has also determined that polished ceramic surface is give less enamel wear in comparison to glazed surfaces. This is very, very important. Okay, so clinically, after we do occlusal adjustment, trimming of the high bite, we need to ensure that we polish the restorations properly, because rough ceramic surface actually produce a lot of wear. All right, so look at another paper. So this is an in vitro paper, a lab test. Okay, they look at the wear of the natural teeth against a monolithic zirconia. Monolithic meaning to say you actually mill out the zirconia as one whole crown. You do not layer them at all. All right, so this is by means of monolithic. And sometimes in order to get better aesthetic outcome, as we all know, zirconia tend to be more opaque, although nowadays the 5Y, the 5% yttrium contained zirconia tend to be more translucent. But for the technician to achieve high aesthetic outcome, sometimes they layer it to give a better translucency. So comparing the monolithic and then layer and various finishing procedures, unpolished, unglazed, polish, unglazed, and polish and glaze. So the outcome is they found that monolithic, polished, unglazed zirconia is the best outcome for wear friendly against natural teeth. And the polished surface in both groups, mean layered or monolithic, has less to wear in comparison to the glazed surface. Because sometimes for glazed surface, it depending on how you paint the glaze. So if you have a lot of pooling of the glazed liquid on the restorations, they tend to be quite rough. So that is the reason why this research has found that the glazed surface tend to give more wear to the opposing natural enamel. So this is concurred with a lot of other literature as well, which gives the outcome of polished zirconia tend to be less wear on the opposing enamel. Okay, another common complications in fixed prosthodontic is the periodontal breakdown. So periodontal breakdown can due to poor design of the prosthesis, the plaque retention due to poor margin fit, the faulty crown margins, over contour crown. A lot of time over contour crown may be the fault of the clinicians because you haven't give enough room for the technicians to create a good margin at the gingival area, which I will show some clinical cases with you. And inadequate embrasure area as well. Sometimes because of the short clinical crown height, the connector area need to have adequate dimension to avoid fracture. For example, for metal, normally we say 2 by 2 by 2. Meaning to say occlusal gingiva about 2 millimeter and the bucco-palatal 2 millimeter as well. But for ceramic, they tend to need a bit bigger, larger area of connector. So if you have short clinical crown height and you have prescribed for a zirconia, for example, zirconia or lithium disilicate anterior bridge, then the technician got no choice but to have a bigger embrasure area. If you encroach into the periodontal space or the so-called periodontal area, patient is not able to clean it. So in the end, you will end up with periodontal breakdown scenario. So these two front teeth, 1-1 and 2-1, has poor fitting crown margin. And you can see they end up with gingival inflammation. You can see in other places, like for example, the canine. The gingiva is healthy and the lower anterior gingiva all healthy, meaning to say that the patient actually have fair oral hygiene. The 1-2 actually have a composite. Again, you can see the marginal gingivitis as well. Okay, so this patient came to me. Her complaint is actually foul smell and difficult to clean between the teeth. The main reason for this concern is because all the 5 anterior crowns are linked together. The patient is not able to floss through at the interproximal area. And you can see at the back as well, the embrasure area, it's very difficult for the patient to keep clean and food gets stuck there because it's concave inside. So unable to floss in between, inability to clean underneath the concave surface of the palatal side has caused the foul smell for this patient. And these few crowns are not old crowns. They just been issued about 2 years plus when the patient came and see me. So we have to explain to the patients that unfortunately, we have to remove all the crown and redo all the crowns. So we need to avoid all these pitfalls as such. So crown preparations need to have clear, good margins. This is when we remove. You can see that the margins are not clear. So besides linking all the fried crowns together, another issue is there is no clear margin. So the technicians have overbuilt the crown at the gingival margin. So these two are the pitfalls that we should avoid. So we solve the problem by redefining the crown margins and place individual crown. So after removing the prosthesis, we put in well-fitted provisional crowns so that we give time for the gingiva to heal. So after a few weeks, once the gingiva is healthy, you can see how healthy is the gingiva now. Then we take impression and fabricate the prosthesis. All right. So do not link the crown unnecessarily because it just complicates the matter of maintaining hygienes. So another case, Miss Wong, she came to me, have unfinished lower prosthesis. So all this lower teeth from 3-6 up to 4-5, 4-4 are all in provisionals. So upper teeth has been done actually. Okay, so you may say that, oh, it's glaringly white, but that is what the patients requested for. So what happened is she went outside and she wants to improve her smile, and it was planned as such that it's almost like a full reconstruction cases that give her a makeover smile. So she has all her upper, which she is relatively happy with. When treatment is proceed to the lower, she was not quite happy with what is to be cemented to her. So she refused to accept those crowns and she ended up with our clinic. So we remove all the old, the provisional restorations. This is the state of the gum, very inflamed due to poor fitting. You know, the margins is actually there and it's actually over prep, but I can't see the margin at that time because of the inflamed gingiva. So I have to electrocauterize. This is immediately on the same visit after removal of the provisional and electrocautery. So you can see that the crown is quite over prep. You know, lower anterior teeth are also fiddly, so thin, and you over prep. In the end, what happened is the two anterior incisors actually become non-vital, unfortunately. So we have to do RCT and then we proceed with the treatment thereon. So we provide good fitting provisionals for a period of time, allow the gingiva to heal prior to taking impression, because one of the prerequisites for a good impression is you have to have good gingival health. All right. So this is interim period with our provisionals, and then we proceed. This is the final restorations that she has requested for, especially the shade. You can see she really wants what we call like a toilet bowl white kind of prosthesis. All right. So another failure that I have outlined at the beginning of the presentation is secondary caries, eventually leading to pulpal necrosis due to poor design of prosthesis, plaque retentive area, patient are not able to keep clean. You know, patient always need to have a follow-up appointment. If you have provided prosthesis to the patients, always schedule recall patients to ensure that the prosthesis doesn't have untowards happening. All right, and each time patient come, you need to reinforce oral hygiene as well. A lot of patients are under this idea that, you know, when you put in a cap, to layman, crowns and bridges like a cap. When you put in a cap, it's like magic protection. They don't really need to take care anymore. Little do they know, at the margin, you have your own natural teeth and caries can occur. You know, as long as you have hydroxyapatite there, you have natural tooth structure there, caries will occur. So this is a very important message to drive home for the patient. So this is the patient. He has his two anterior crown done some time back. You can see that the margin fitting is poor. In fact, someone has tried to put a composite to you know, sort of get away with the deficient margin. Unfortunately, the secondary caries happen. You can see how deep this is at 5 millimeter mark. My probe can actually go in for 5 millimeter. And from X-ray as well, you can see the secondary caries has set in too. So we explain to the patient, we have to remove the crown for 2-1 and evaluate and see. If we are not able to save, which, you know, we foresee that chances of saving 2-1, it's very, very slim. So true enough, we removed it. We are not able to save, we have to extract it. And on the same visit, what I did is, instead of an immediate denture, I put what I myself term as sort of an emergency or immediate bridge. So this is not using fiber. What I did is, I take a denture tooth, modify as such that fit into that particular space, and I put a little bit of flowable composite to adhere it to the adjacent tooth, because 2-1 has become non-vital on incidental finding while we're trying to do the EPT test. All right, and also on X-ray, it has a PA lesion. So while we're carrying out the RCT for 2-2, we temporarily put denture tooth and cement it, sort of cement it adhesively with a little bit of flowable composite to the adjacent tooth. And eventual treatment plan is to have a fixed bridge. All right. So the advantage of having a immediate provisional like this is you are able to scalp the gingival area. You know, they give you that leeway to scalp the area so that you can have a good emergence profile. if you were to put for example, immediate denture, it will not have that kind of effect. So you can see after about 4 weeks or so, that area has been scalped nicely. This is a provisional in place. And eventually you get a better emergence profile for your final prosthesis. So another case, this is Madam Sue, and she complained of a shaky bridge. The bridge is from canine to canine, 6 unit. Usually for fixed prosthesis, we say that for anterior is maximum 6 unit, canine to canine, and for posterior maximum 4 units. So this has been published in BDJ as a guideline. So Madam Sue has come in, complaint of a shaky bridge. So this is a video of the shaky bridge. You can see that, you know, the bridge is actually moving. You can see the bubble from the saliva is moving too. So we remove the bridge, and unfortunately, the 1 tree is beyond salvageable. So we can't really save it. So treatment plan that we propose to her is either implants or removable prosthesis. She's not ready for removal at all. She was almost on the verge of crying when we say that she needs to wear denture. So she said no, and yet she cannot afford to have implant. So after long discussion, because you can see previously there is somehow like a plastic crown on the 1/4. So we say, okay, I think this must be one in my lifetime that I do a 7 unit bridge like this. Okay, so although it defies the principle, but you know, patient was begging and begging that she cannot afford implant. So I said, okay, fine. We try with guarded prognosis. And what I can do on my part is we control the occlusion. So you can see occlusal contact is very, very important to maximize the outcome success. So in this, you can see there is excursive forces. So we need to remove the excursive forces. So we try to minimize the excursive forces on the pontics and put it on the abutment teeth, which is the natural teeth, 1/4 and 2/3. And she's happy. So I've been reviewing her every year for the past 4 years. So far, things are stable. Okay, the last case that I would like to share. Dato, is that okay, or we need to stop now? It's 10:30 now. So would you like me to stop or just continue quickly with this case?
Yeah, many more slides? Yeah.
Yeah, last case.
Okay, just go on. Just go on.
Yeah, thank you. Okay, just last case quickly. Madam Sue, this is Madam Sue. She came in, she doesn't like the look of her anterior teeth. And also you can see other teeth are all very heavily restored with large composites. So the issue here is she has anterior cantilever bridge that link 1/1 and 2/1 with poor fitting margin. So with this poor fitting margin, secondary caries happen as a previous case. So this is what happened when we when we remove the prosthesis. Link 2/1 and 1/1 together, cantilever 2/2. So there is lots of caries here on the tooth 2/1. So we discussed with her, it has a big, large metal post in it. So we explained to her the risk of root fracture if we were to remove it. If we do not remove it, prognosis is very, very guarded because we are not sure with the long-standing caries whether the root is contaminated or not. But she said, okay, she is willing to accept the risk and just retain the root because she really don't want to risk losing that tooth anymore. So fine, we try our level best, we clean up all the caries, we rinse it with chlorhexidine, and then we restore it with composite. And then the rest of the teeth, we just prep it for crown because they have large composites on most of them. So treatment plan, how to replace tutu, the missing tutu, bearing in mind 2-1 has guarded prognosis. So I don't want to link it with any other abutment teeth for fear that in the event that it fails, I only need to deal with one single tooth. So we have treatment plan as such that this one will be fixed bridge, cantilever the tutu. 2-1 maintain as one single crown. In the event that it fails, we need to extract it, perhaps place an implant without compromising other prosthesis. So taking shades, this is the lab process, firing of the ceramic, and this is the finished case in the patient. All right. Okay, thank you so much for your attention, everyone. And once again, thank you to Dr. Professor Muhammad Ibrahim and ICD for the invitation to share my experience with all of you. Thank you.
Thank you very much, Professor Liang, for the very informative and also lecture with all the illustration. And in the Q&A, we have 2 questions there. The first one is, may I know how many millimeters of bone do you remove during the crown lengthening procedure?
Well, we remove about 2 millimeters. For the first case, I presume that was us.
Yeah. And then the second question is, do you etch the tooth when you use flowable composite to cement the temporary denture?
Yes, I etched for the case that I put the denture tooth on the denture tooth itself, because the denture acrylic doesn't really bond well with the flowable. So I actually use a small round burr, drill 2 holes in the denture tooth to improve the retention. On the natural tooth, I etched, but I didn't put any bonding agent because this is a temporary measure. So I need to be able to remove the flowable composite in the event I'm not prepping. But in this particular case, because I'm prepping the adjacent tooth as well, so I actually, it doesn't really matter. I can actually use bonding agent. In the event that you are not using that adjacent tooth as a retainer, then you don't use bonding agent. Just etch and a little bit of flowable composite, just temporary to keep it for maybe a few weeks or so.
Okay, the last question, I think this one linked to your last case. I think this asks, when is it necessary to link crowns?
We do not link crown at all as much as possible, because link crown has its issue. First, patient are not able to keep it clean. Patient not able to floss. So usually cantilever bridge, 1 retainer, 1 single crown, cantilever to a pontic. Because you can see the cases that I have shown, link crown comes with a baggage of problem.
Yeah. Okay. All right. So I think that's the 3 questions we have. We have here Dr. Prof. Arshad Malik, the Vice President. You want to speak anything, Prof. Arshad?
First, I will pay thanks to you, Datu. It's an excellent presentation, and what the choice you always used to do to select the proper excellent speakers from Malaysia, and these are excellent faces and so brilliant knowledge up to date. Lady, there are one or two the things which I have observed in your cases. One thing is that you are using electrocautery, and
Yes.
Ibrahim will be agree with me that we maxillofacial surgeon we are very conservative at using the cautery around the teeth. And especially if we are going to have the periodontitis, or sometimes if we are touching the tooth, we are going to have the pulpitis, or sometimes it may lead to irreversible pulpitis. And that the things which we used to observe. And for that purpose, we used to prefer the laser, a diode laser or like that, because it do not hurt the periodontium, or it do not hurt the tooth. First, my reservation regarding your cases is that why you are using electrocautery, because in very minimum wattage, if we are using, then it is also going to hurt the pulp and going to hurt the periodontium. My second question is that when we are going to repair the zirconium, or when we are going to repair the porcelain, and we used to have the sandblast or anything, we used to give the opaque as well, and we try to compensate the patient without removing the crown, and we try to repair it right there. But certainly I have seen, maybe that Ibrahim will be agree with me, that we do not find the absolute matching of that color which we used to have the original one. Either it is the time passed, because we cannot, it is a new color and that is the old one. What is the, I don't think that why it is not so matching. That is my two observation, which I will like to have your comments.
Thank you so much, Professor Malik. It's excellent questions. First is the electrocautery. To be honest, I use it quite a lot. But I must say, when you do electrocautery, you have to be very careful. You use it like a paintbrush, and you do not touch a tooth at all. Because when we do electrocautery, the tip is quite small. So you can actually control it and do not touch the tooth at all. You use it like a paintbrush. You know, you don't stop at one particular area for more than a few seconds. So even if it really accidentally touched the tooth a bit, it will not cause pulpal necrosis, because we all know the tooth needs, the pulp needs to have increased temperature of about 4 degrees before necrosis would set in. So that is the upside of using electrocautery. And not every practitioner would have a laser machine in their clinic, where most of them would have electrocautery set in the clinic. So it will have success outcome. So far, touch wood, I haven't got any patients complaining of untoward event after electrocautery. So in the event that if there is amalgam restorations at all, then extra care should be there not to touch the amalgam restorations at all. So far, in general, if you used it carefully and correctly, it will not give untoward outcome. The second one is the color matching. Yes, it is a challenge to repair and have a good color matching, I must say. But I think with a little bit of practice and experience, you can achieve a quite good outcome. It's just similar to doing direct composite veneer for aesthetic purpose, you know. And also to remove the whole prosthesis and redo, it's not only cost money, it also have biological consequences as well. In the event, when you remove the prosthesis, you may accidentally trim it a little bit more, or you may fracture the tooth even. You know, especially if you have a long span bridge and it's relatively new bridge, you really don't want to remove the whole prosthesis. Thank you so much, Prof. Malik, and thank you so much for joining the webinar.
Okay, thank you, Rosia. I think you since you are very used to electrocautery, I think you had take extra care of using the electrocautery. Of course, using a laser be much easier. I think if you have the laser. Anyway, I think that's
Yeah,
all.
I totally agree. I mean, laser, of course, is a better alternative, but not every single practitioners would have laser in their practice. So
Yeah. Right. Thank you, Professor Xiao, Liang Lin, and all our attendees tonight. And on behalf of Section 15, we'd like to thank you for your sharing your experience, your knowledge, your skills with all our participants tonight. Tonight we got about nearly 170 who has logged in to listen to your lecture. I think it's a very interesting one. Thank you very much, Professor Xiao. Okay,
thank you so much, Dato, for the opportunity. Thanks, Prof. Malik. Hopefully, we will be able to meet face-to-face very soon.
Okay, as usual, I would like to make some announcement for our next meeting. But before that, I'd just like to share with our participants that in December, from 10 to 12 of December, ICD will be hosting a conference and induction in Phnom Penh from 10 to 12. So please do join us. This is a preliminary announcement, and we have 3 days, one day workshop and 2 days conference. And also the fees are quite reasonable, especially for students. So please join us for this Congress in December in Cambodia. So that's the first announcement. The second announcement is our meeting for next month. Next month we will have a speaker from Pakistan.
It's long lying link brochure. Is it there?
Sorry?
Just see that whether it is Johariya or it is Lin.
Johariya. Is it Professor Johariya?
Okay.
Okay, it's from she'll be talking about OPMD and dental lasers. We are underestimating the relationship. It's on the 16th of November, same time at 9:30. So do join us for our November meeting. And again, for those who have joined us tonight, thank you. And see you all there again in 1 month's time from tonight. All right. With that, I think we will close our webinar today. And thank you all for joining our meeting tonight. Thank you and good night.
Okay, thank you. Good night, everyone.
Right.